Hello, my friends, again. This is Dr. Laif Tahir, a specialist in anesthesia and intensive care. Last time we spoke about acid base balance, and I promised you to speak about diuretics. That's what we are doing today. I will speak about diuretics in detail, yet in a short time. In the last lecture, we talked about the nephron, which is the smallest unit in the kidney. It consists of a glomerulus and a tubule. In the glomerulus, the afferent arteriole comes to the kidney and give a tuft of capillaries, then leave as the efferent arteriole. There, the exchange of substances happens between the arterioles and the Bowman's capsule. After that, these substances are part of the tubular fluid that continues in the tubule. The tubule, as we said in the last lecture, consists of the proximal convoluted tubule, the lobe of Henle, the distal convoluted tubule, and the collecting duct. Now, the proximal convoluted tubule, it's proximal because it's close to the glomerulus, while the distal convoluted tubule, it's distal because it's distal to the glomerulus. You are a great person. Now, the lobe of Henle consists of three parts: descending lobe of Henle, thin ascending lobe of Henle, and thick ascending lobe of Henle. Why are we talking about these parts? Because the diuretics work on these parts. Today, I want you to remember 5 families of diuretics: the osmotic diuretics, the carbonic anhydrase diuretics, the lobe diuretics, the thiazide diuretics, and lastly, potassium-sparing diuretics. These are 5 families. In each family, we have multiple members. Now, each of these families works on a certain part of the tubule. The first part, which is the osmotic diuretic, it works on the proximal convoluted tubule. The second one, which is carbonic anhydrase inhibitor, it works on the proximal convoluted tubule and the glomerulus. The third one, which is the lobe diuretics, I think from the name it's obvious that it works on lobe of the fourth one, which is the thiazide diuretic, it works on the distal convoluted tubule. And the last one, which is potassium sparing diuretic, it works mainly on the distal part of the distal convoluted tubule and the collecting duct. You should memorize them to this order, from the proximal part of the nephron to the distal part. Now, each one of those 5 families of diuretics has one famous member. So, I want you to memorize this famous member. So, for the osmotic diuretics, we have mannitol. For the carbonic anhydrase diuretic, we have acetazolamide. For the lobe diuretic, we have the lasix with the scientific name of furosemide. And for the thiazide diuretic, we have chlorothiazide. And for the potassium-sparing diuretic, we have sprinolactone. What do diuretics do? From the name, I think you will say it increases urination. That's great. But if your medical school and university taught you that diuretics' objective is to increase urination, it would be a bad university. Why? Because we have 5 families for 5 different uses. So each one of these families is used for a different purpose. There are different classes. So the mechanism is by increasing urination, but the objective of the drug is different. So the osmotic diuretics, they are used in the increased intracranial pressure. If someone is hit on his head and there is a great pressure inside his cranium, you would give him mannitol to decrease the pressure. While acetazolamide inhibitors, they are used for increased intraocular pressure. So if you are having glaucoma, which is increased pressure inside the eye, you would give acetazolamide. For the lasix, the furosemide, the lobe diuretics, it's given to treat edema, especially pulmonary edema like heart failure patients or peripheral edema in the legs, etc. While the thiazide, like chlorothiazide and hydrochlorothiazide, they are the best treatment for essential hypertension. Essential hypertension is hypertension not caused by a secondary cause. We always give hydrochlorothiazide or any thiazide. While potassium-sparing sprinolactone, it's used in heart failure. But here it's not symptomatic as lasix furosemide. It's here it decreases mortality in heart failure. So we have four types of drugs that decreases mortality in heart failure. This is always a question in the exam. It's ACE inhibitors or angiotensin receptor blockers, ARBs, or beta blockers, and finally, potassium-sparing diuretics. These are the only four categories that decreases mortality. Regarding the beta blockers, they are either carvedilol, metoprolol, and bisoprolol. Now let's talk how each of these diuretics works. Mannitol acts as a sponge. So when it's inside the vessels, this sponge takes out the fluid from everywhere inside it. So it draws fluid from the brain, from the cell inside the vessels. That's why it decreases intracranial pressure. Now, when it reaches the glomerulus, filtered but not reabsorbed or secreted, it stays inside the tubular fluid. So it absorbs more and more fluid from the body inside it. So this sponge is called the mannitol. Secondly, acetazolamide, which is a carbonic anhydrase inhibitor. Now we know that CO2 with water makes H2CO3, which is carbonic acid, which dissolves later to bicarb and hydrogen. And if we go vice versa, bicarb and hydrogen, when they unite, they also use carbonic anhydrase. They use carbonic anhydrase enzyme. So if we inhibit this enzyme, we will prevent bicarb and hydrogen from uniting, and we will lose bicarb in the urine. That's why carbonic anhydrase inhibitor causes acidosis. Now, if we go to the loop and thiazide diuretic, I always put them together. They causes fluid loss in urine and all electrolyte loss in urine. So, both of them causes loss of sodium, loss of potassium, loss of chloride, etc. The only difference is something related to the parathyroid hormone. We know that parathyroid hormone secreted in the parathyroid gland, it increases calcium and decreases phosphate in the body. So the thiazide works like parathyroid, increases calcium reabsorption, while the lasix or loop diuretics, it increases calcium excretion. So the thiazide causes hypercalcemia while lasix causes hypocalcemia. This is the only main difference. So if you are having hypercalcemia due to hyperparathyroidism, you will use loop diuretics like lasix. But if you're having massive loss of calcium in the urine, which causes stones, you are having hypocalcemic hypercalciuria, you will use thiazide, because thiazide will decrease calcium in the urine. Now, both of them, they causes extra excretion of hydrogen in the urine. That's why they cause alkalosis, and it's metabolic because it's in the kidney. Lastly, the potassium-sparing diuretics. They are two major classes. The first class inhibits epithelial sodium channel in the collecting duct, while the second type is an aldosterone antagonist. It inhibits aldosterone receptors in the distal part of distal convoluted tubule as well as the collecting duct. The first class, which works against the sodium epithelial channels, the most famous one is amiloride, while the second group we talked about sprinolactone, it's the most famous one, and ibrinolone. Now, we said in the suprarenal gland we have three areas: zona glomerulata, zona fasciculata, zona reticularis. You can memorize it as GFR. In the zona glomerulosa, you have aldosterone. It reabsorbs sodium and secretes potassium and hydrogen in urine, so it causes hypernatremia, hypokalemia, and alkalosis. So if you prevent aldosterone, you will have the opposite. So sprinolactone, it causes hyponatremia, hyperkalemia, and acidosis. Amiloride, it doesn't prevent aldosterone channels. It's not related to aldosterone. It works on sodium channel, but the net effect is the same. You will have low sodium in the blood, but high potassium and high hydrogen. So these drugs, the last group, potassium sparing, it's used for heart failure, mortality decrease, and the aldosterone antagonists, they are used for hyperaldosteronism, which is called Conn's syndrome. Now, what about the side effects of these drugs? If we go to the loop diuretics, it causes decrease in all electrolytes, which might cause malfunctioning in the body. So it decreases sodium, potassium, hydrogen, etc. But the only thing it increases is uric acid. That's why it causes hyperuricemia. In the thiazide, it's the same except for calcium. So it causes hypercalcemia, hyperuricemia, and two extra things which always come in exams. It's hyperglycemia for sugar and hyperlipidemia for lipid. Both of them also causes orthostatic hypotension, which is decrease in blood pressure when someone is sitting and stand up, because the gravity will work more and more. In normal people, this change is minimal, but in people who have certain causes, like taking diuretics, it might cause orthostatic hypotension. In this case, the percentage is so large that it's problematic. For the potassium sparing diuretics, it causes hyperkalemia, it causes acidosis, and it causes hyponatremia. Now finally, I said these families have famous members, celebrities, but also it have other members you shouldn't be familiar with. So if we go to the loop diuretics, it has furosemide, ethacronic acid. And I want you to concentrate on the last one. While the thiazide, we have chlorothiazide, hydrochlorothiazide, chlorothalidone. In potassium-sparing diuretics, we said we have amylouride, which works against sodium channels, and we have sprinolactone, which works against aldosterone receptor. There is something called sulfonamide allergy. So some drugs like sulfonamide antibiotics, which contains sulfur, it causes allergy that might be severe to patients. Many of the diuretics we mentioned today can cause the same thing, sulfonamide allergy. It includes the carbonic anhydrase inhibitors, the loop, and the thiazide. As the potassium-sparing diuretics don't cause the same thing. So carbonic anhydrase inhibitor like acetazolamide, loop diuretics like furosemide and taurusemide. You are clever if you notice that I didn't mention ethacronic acid. And finally, thiazide diuretics like chlorothiazide, hydrochlorothiazide, and indapamide. All of these cause sulfonamide allergy. Whereas ethacronic acid is the only exception in the loop diuretics, and they always ask about that. In addition, sprinolactone, ibrinolone, amylouride, the last four, they don't cause sulfonamide or sulfur allergy. Thank you, my friends, for watching this lecture. Please like, comment, and share, and don't hesitate to watch the next one.